AIDS Society, and on behalf of the webinar this afternoon, I just want to tell everyone that we are preparing to start in the next few seconds to minutes. We're on the hour, but we're just waiting for a few more people to actually get on board, and we'll be starting in a few minutes. So thank you for coming again. Hello everyone, it's my great pleasure this afternoon to welcome you all to a webinar entitled The Double Burden, HIV and Cervical Cancer. And this webinar is hosted by the International AIDS Society and Pink Ribbon, Red Ribbon. Before we get started, there are just some housekeeping items that we need to cover. Just so everyone knows, we are expecting a large number of people very happily on this webinar this afternoon. So we will keep everyone muted until the end for question and answer. So with that in mind, we ask everyone who's not speaking to put your computer microphones on mute so we can limit the amount of background noise. Please also be aware that we have a chat box function. And so as you think of questions as we go through the talks this afternoon, please feel free to actually record your questions in the question box, in the chat box, and we will assemble those questions to be answered towards the end of the webinar. We will also, if necessary, have an opportunity for people to actually call in, but given the numbers of people on the webinar this afternoon, I think that chat box is probably going to be the most efficient way for us to hear your questions. The added benefit being that any questions we don't have time to get to, we will record and make sure that those questions are answered. So without further ado, let's get started. And it is my pleasure to introduce myself, Linda Gale Becker. Welcome. Thank you for joining our webinar today. It is entitled The Double Burden, HIV and Cervical Cancer. And as mentioned, it's co-hosted by the IAS and the Pink Ribbon, Red Ribbon. I am currently the president of the International AIDS Society, and I will be your host on the webinar today. Over the course of today's call, we will be talking about the very important link between HIV and cervical cancer. And it truly is my great pleasure to say that I am joined today by the CEO of Red Ribbon, Pink Ribbon, and just to welcome Dr. Selina Shokin in that capacity, and she will, in a moment, introduce our fantastic lineup of speakers and panelists. So again, we will be going through this topic in quite a bit of detail. We will introduce our speakers in a moment, and at the end, we'll open up the call for questions. Just as a little bit of background to this problem, and we are going to get into it in great more detail in a moment, it speaks to an unholy alliance between two infections that really bring a great deal of morbidity and mortality to today's global HIV epidemic. And, it must be said that in the advent of universal access to treatment, and of course easy to take low side effect antiretrovirals, we have seen an enormous benefit of treatment in the global HIV epidemic. This has happily led to a reduction in mortality and, of course, the extension of the average lifespan in all genders and most populations throughout the world. This, in turn, has led to a much larger treatment pool of people successfully living with HIV and now facing the prospect of middle and even old age with chronic HIV infection. And this really is where the unholy alliance of the co-infection of human papillomavirus comes in, and it's a problem that women face around the world. So we understand that women are particularly vulnerable to both HIV and HPV, and those who are living with HIV virus are more likely to be HPV co-infected and more likely to have persistent infection. These women then in turn are more likely to experience the sequelae of persistent HPV infection, too often resulting in untimely cervical cancer, and recognizing that this subject is so important because HPV is both preventable and the sequelae are treatable. So today we have a great lineup of experts to help us understand this problem. Quickly, before we get into the actual webinar, however, I do want to remind you all, and I would be remiss if I did not, remind you that we are leading up now to a very exciting meeting in Paris, France in July 2017. It is the 9th International AIDS Conference on HIV Science, and we expect more than 6,000 of people like yourselves to attend that conference, and we're looking forward to you joining us there. A key theme at the IS 2017 will be the interaction of HIV with other fields of medicine, in particular cancer, and some of the co-infections that really increase morbidity. So additionally, the first HIV and Cancer Cure Forum will take place just prior to IAS 2017. It'll be just before the actual conference itself, and it will focus specifically on the interface and similarities between HIV cure and cancer research. And we really are expecting that both fields will learn a great deal by sharing and dialoguing. And this will be the first of many conversations, I'm sure. So let's then, without further delay, move on to the webinar itself. And as mentioned, it is my great pleasure to introduce you to Dr. Selina Shokin. She is an unrivaled champion of women's health issues. She's worked in both the developed and the developing world, and she really brings a wealth of experience and expertise to today's webinar. And I will hand over to her and ask her to say a few opening remarks and then introduce the speakers. Over to you, Selina.
Thank you so much, Linda Gale, and to IAS for co-hosting this webinar with us. So cervical cancer is recognized to be a comorbidity of HIV and AIDS, and it's a defining cancer. Research has shown that HIV-positive women are 4 to 5 times more likely to develop invasive cervical cancer. And HPV infection moves more quickly in HIV-positive women. And we see women presenting with cancers at a much younger age, often even in their early 30s, that have HIV infection as well. Most cervical cancer cases occur in low resource settings, And the high rates are tending to correlate with high HIV endemic countries. So in countries with a strong HIV burden, we see much more cervical cancer. Another challenge that we face is that cervical cancer today is where we were several years ago for HIV in relation to stigma. Because there's little access to testing and to treatment, the stigma is high. If we can increase access to testing and to treatment, we hope we can bring down the stigma of this disease. There's clearly a need for research on the two diseases, as well as more programming to address both HIV and cervical cancer. Despite the increasing burden of cancer in low resource settings, there's limited funding that's available. This chart shows the proportionate deaths and funding in low and middle income countries in 2012. There were twice as many cancer deaths as HIV deaths in 2012, but the total cancer funding in low and middle income countries is about 2% of the funding available for HIV and AIDS programs. So we see here a huge opportunity to leverage HIV platforms because these are the people that are most at risk for cervical cancer. Cancer has become a leading cause of death worldwide, with about 14.2 million cancer cases and 4.8 million deaths in 2012. And these cancer deaths are growing. This creates a major challenge for ministries of health, for governments, and for development agencies. 2/3 of cancer cases are expected to occur in low and middle income countries by the year 2020. So Pink Ribbon, Red Ribbon was founded by President George Bush, who created PEPFAR, the President's Emergency Plan for AIDS Relief, after he left office. And we're an independent affiliate of the George Bush Institute. Our partnership was founded by the Bush Institute, the U.S. government through PEPFAR, UNAIDS, and Susan G. Komen. And to date, we have more than 30 foundations, nonprofits, governments, and corporate partners. We run our activities through a small headquarters based in Washington, D.C. So as I said, we're a large public-private partnership with governments, multilateral organizations, foundations, and corporations. And we raise money and run programs to save women's and girls' lives from cancer, where the burden is greatest. We work very closely with national leaders to build long-term, country-led, sustainable programs. We're currently active in Botswana, Ethiopia, Tanzania, and Zambia. And you'll be hearing a bit later from Dr. Sharon Kapambwe about the program in Zambia. The epidemiology of cervical cancer and the national response to the disease, as well as the burden and response to HIV, are considerations as we build new programs. This year, we plan to expand into Mozambique and Namibia through the PEPFAR platform, in large part because of the very high burden of both cervical cancer and HIV in those countries. Most of the Pink Ribbon, Red Ribbon programs to date have been implemented with PEPFAR funding to provide services for cervical cancer screening and treatment to HIV-positive women or women at risk. In Zambia, Tanzania, and Botswana, our program started with PEPFAR funding and have been supplemented with funding from the private sector, foundations, and other organizations. And in Ethiopia, we started our programs with private funding, and PEPFAR has come on to supplement this funding due to the success of the programs. So what exactly does Pink Ribbon do? We've been focused on data and development, helping to develop global standards, tools, and guidelines for managing the disease and for monitoring and evaluation. We also work on education, awareness, and advocacy. There's really low awareness about the disease, both in country and at the global level, so advocacy is extremely important. And we need to make sure that at the country level and at the community level, that people understand the disease, that we can start reducing the stigma of the disease with better information. And also by providing training and equipment. So we work with both public and private providers to screen and treat for cervical and breast cancer. Another important element of cervical cancer prevention is the vaccination. We have an excellent vaccine against the human papillomavirus, and we work to increase access to the vaccine for girls throughout Africa by educating people about the vaccine and helping plan for vaccine scale-up. Screening for women's cancers can be done with simple, low-cost methods, such as clinical breast exams for breast cancer, visual inspection with acetic acid, or VIA, and HPV diagnostic testing for cervical cancer. And once we identify women that have cervical precancer, we can treat them very easily for a low cost using cryotherapy, thermal coagulation, and when needed, LEEP, or loop electrosurgical excision procedure. We also support women who need more advanced treatment. Because there is so little testing that's available, we find that many women are presenting with later stage cases, so we need to be able to provide them with advanced cases and treatment when necessary. As a public-private partnership, we look to pool and leverage resources to most effectively reach women in need. ARV clinics are a natural starting point to offer cervical cancer screening and treatment, and we follow this model in many of our countries, including Zambia, which you'll hear more about later. So in these countries where we work, our success is built on the PEPFAR platform and by leveraging strong networks for the care and treatment of HIV. As you can see, we've already screened 341,000 women for cervical cancer, and we've treated nearly 25,000 women for cervical precancer or cancer. We've recently revised our data and M&E systems to be able to disaggregate women screened and treated by HIV status. And we're expecting to have stronger data to support the impact and need for integrated HIV and cervical cancer programs in the next year. Anecdotally, when I was in Botswana last month, our implementing partners there told us that between 60 and 80% of the women who test VIA positive are also HIV positive. So this is further evidence of that link between HIV and cervical cancer. Now I'd like to turn the floor over to our next speaker, Dr. Corey Casper, who's a researcher and a medical doctor. He holds positions at the University of Washington and the Fred Hutchinson Cancer Research Institute, and has experience researching AIDS, AIDS-associated cancers, and global health. He's been instrumental in building the Uganda Cancer Institute and has spent a lot of time there. As you can see from the many titles Corey holds, he's a pretty accomplished guy. Corey will talk about the epidemiology and prevention of HIV and cervical cancer.
Thanks so much, Selena. I really appreciate the great introduction and the opportunity to be here with everyone today. I want to just reemphasize, maybe on my next slide, the point that Selena just mentioned, which is that cancer is becoming an increasing threat to health across the world. 2/3 of new cancer cases by 2020 will be in low and middle income countries. But more than that, the spectrum of cancers that we see across the world differs dramatically by where you're sitting. So on this map here, you can see what is the most common cancer by country across the world. And you can see that in sub-Saharan Africa, really in many parts, the most common cancer that is seen there is cervical cancer. On the next slide, I want to just make sure that everyone is aware of the special relationship between HIV and cancer. So in 1981, the global HIV pandemic was heralded by an outbreak of Kaposi sarcoma in the United States. And this was really the beginning of the AIDS epidemic. As Selena mentioned, in the subsequent years, 2 other cancers were determined to be AIDS-defining illnesses. And for those of you who don't remember back almost 3 decades, those AIDS-defining illnesses were illnesses that meant that an individual had AIDS before we had a test for HIV. And these illnesses were exceedingly more common in people with AIDS than people without in the general population. So Kaposi sarcoma, lymphoma, and cervical cancer all were of epidemic proportions in the early HIV epidemic. We now know that overall, HIV increases your risk of cancer up to 3,000-fold compared to someone of the same age and gender who's HIV negative. And we also know that for every 100 patients that's followed in an HIV clinic, and these data are consistent either in North America or sub-Saharan Africa, about 1 out of every 100 patients followed every year in an HIV clinic will develop cancer now. So cancer and HIV are as Dr. Becker said, are intricately linked. And I think that we need to develop strategies for dealing with this epidemic of cancer that is in the wake of our successful control of the HIV pandemic worldwide. Next slide, please. So in addition to cancer being very common in people with HIV, it's also very morbid. And you can see on this next slide in 2 different settings. On the left is a study that was published for patients with HIV and cancer in Italy. And on the right are data that we've generated from Uganda. And they look remarkably similar. In both settings, your risk of dying if you have cancer and HIV is up to 2-fold higher than if you have cancer without HIV. The graph on the left shows a wide range of cancers, with the orange bars representing the survival in people who are HIV negative, and the green bar is in HIV positive, and that's survival at 5 years. And you can see that overall, about 65% of patients with cancer who are HIV negative are alive 5 years after their diagnosis, but only about 40% of patients who are HIV positive are alive 5 years after their diagnosis in Italy. Similar data are hard to come by in sub-Saharan Africa because it's harder to have long-term follow-up of patients with cancer. But if you look 1 year after diagnosis, you see very similar trends, where about 70% of patients who are HIV negative are alive a year after their diagnosis with cancer, and about 45% of HIV positive patients are alive 1 year after being diagnosed. So about half of patients diagnosed with cancer in the setting of HIV will be dead 1 year after their diagnosis in Uganda. Next slide, please. So it's important to think a little bit about cervical cancer specifically. As the graph showed us, it is becoming the most common cancer in several countries in sub-Saharan Africa, especially in those places where HIV is very common. So what is the unique relationship between cervical cancer and HIV? Well, as was mentioned previously, women with HIV are about 5-fold more likely to be diagnosed with cervical cancer. And the reason we think that that occurs is because there's a spectrum that goes from initial infection with human papillomavirus, the virus that causes cervical cancer, and the development of cervical cancer. So initially, a woman has to acquire a high-risk human papillomavirus type, and that's one of the many different HPV types that causes cervical cancer. Over time, that woman with HPV, who has a high-risk HPV type, will develop cervical dysplasia, and then some of those women will go on to develop cervical cancer. That process is a dynamic one. So in HIV-negative women, we know that many women, about 30% of women who develop cervical dysplasia from HPV infection, will spontaneously be able to regress that lesion back to a normal cervix. But in the setting of HIV, what we know is that that happens much less frequently, and that women who develop cervical dysplasia are unlikely to spontaneously resolve it on their own. We don't really understand the reasons why that happens more frequently in the setting of HIV. This graph in the slide is a complicated one, but what it is attempting to point out is that for almost all of the other AIDS-defining illnesses or AIDS-defining cancers, they occur much more frequently when your CD4 T cell count is low. So for instance, the incidence of Kaposi sarcoma, if your T cells are under 100, is over 100-fold higher than if your CD4 T cells are over 500. And that's true of non-Hodgkin's lymphoma and many other AIDS-related cancers. But as you can see in the graph paneled C here in the upper right corner, for cervical cancer, there is no relationship between the CD4 T cell count and the incidence of cervical cancer. So we know that it's not simply the depletion of your CD4 T cells that leads to cervical cancer, and that there are other factors that are secondary to HIV infection that cause an increased risk of cervical cancer, and we can talk about those in just a moment. So let's go to the next slide. So the other thing that's unique about cancer in the setting of HIV is that many cancers in the setting of HIV their incidence goes down dramatically as people have access to antiretroviral therapy. So for instance, in the United States, the incidence of Kaposi sarcoma dropped tenfold in a single year between 1996 and 1997 with widespread access to antiretroviral therapy. And I think many people in the public health community had hoped that overall the incidence of cancer would begin to decline and eventually disappear, much like many opportunistic infections such as CMV retinitis or toxoplasmosis. We had really hoped that these cancers would go away as people had access to antiretroviral therapy. But unfortunately, the data are not bearing that out. In the United States, actually, the overall incidence of cancer in individuals with HIV is now higher than it was in the pre-antiretroviral therapy era. And these graphs really represent that. So this is a graph showing how in the number of years after initiation of antiretroviral therapy, what happens to the incidence of cervical cancer in large cohorts where this is studied. And you can see that these are essentially, no matter what quadrant of the planet you're in, South Africa, Latin America, North America, or Europe, you can see that these are essentially flat lines. So with each year from the initiation of antiretroviral therapy in a cohort, the risk of cervical cancer doesn't decline. Another way of looking at this is at a population basis, and on the next slide are data that we've generated and published from Uganda. So in Uganda, sorry, if we could just go to the next slide. In Uganda, this graph shows the countrywide coverage of ART in the gray bars. So between 1999 and 2008, about 40% of Ugandans who met international criteria for starting antiretroviral therapy had access to it. Over that time period, you can see trends in the 3 AIDS-defining cancers. Over that time period, as ART use increased, we actually saw an increase in non-Hodgkin's lymphoma, a slight decrease in Kaposi sarcoma, which is the purple line. And for cervical cancer, there was really no relationship between access to antiretroviral therapy and the incidence of cervical cancer. So from this, we conclude that these cancers will continue to be problems as the HIV pandemic matures, and that simply access to antiretroviral therapy will be insufficient to stem this rising tide of cancer. Next slide, please. So again, drilling down specifically on cervical cancer, I showed you data about the overall mortality in patients with HIV and cancer, but these are 2 studies from sub-Saharan Africa, one from our site in Uganda and one from Botswana that was just recently published in the Journal of Clinical Oncology. That look remarkably similar. For those of you used to looking at Kaplan-Meier curves, these curves show that with time, after diagnosis, the percentage of women who are still alive after being diagnosed with cervical cancer. In both graphs, HIV positive women are shown in blue. In Uganda, we have HIV negative women in red, and in Botswana, the HIV negative women are in yellow. But these graphs look remarkably similar and show that essentially for an HIV positive woman, 2 years after her diagnosis with cervical cancer, only 1 in 4 is alive. So 3 out of 4 women diagnosed with cervical cancer in sub-Saharan Africa who are HIV positive are alive 2 years after their diagnosis. So this is an incredibly morbid disease in the setting of sub-Saharan Africa, and one for which we need new strategies. So let's go to the next slide. The fortunate thing on our next slide is that we see that there are a number of different opportunities to prevent cervical cancer, and I've divided them into what's called primary prevention and secondary prevention. So primary prevention for cervical cancer essentially means preventing a woman from even acquiring the virus that causes cervical cancer. So if you can prevent a woman from acquiring human papillomavirus, you can prevent her from developing cervical cancer. And data from the United States suggests that the HPV vaccine is more than 90% effective in reducing the incidence of cervical cancer. So how does that look for women with HIV in areas where there's a high burden of cervical cancer? So unfortunately, the HPV vaccination coverage in sub-Saharan Africa is far from universal. Some estimates suggest that less than 40% of women who are eligible to receive the HPV vaccine are able to have access to it. That's changing, but as of right now, that's what the situation looks like. Unfortunately, because HIV and HPV are both transmitted as sexually transmitted infections, by the time one is acquired, the other one is usually there. So studies suggest that 75% of women who are diagnosed with HIV at the time that they're diagnosed already have HPV. And as many of you know, for women across sub-Saharan Africa, presenting with HIV is often one of the few interactions with the healthcare system. So unfortunately, at that time period where you might offer a vaccine, it may be too late. Now, if you actually are able to find someone who is HIV positive who is not yet infected with HPV, is it possible to vaccinate them at that time and generate a protection? And much like most vaccines in the setting of HIV, unless your T cells are very low, so less than 200, the response to the vaccine is quite good. So HIV itself does not impair your ability to respond to the vaccine unless your T cells are quite low. Although I should also mention that among the many types of HPV, the response to the vaccine varies by type, and unfortunately is less robust for some of the high-risk oncogenic HPV types. So these data taken together suggest that if we can really implement universal vaccination prior to sexual debut, we will have a great shot at beginning to eradicate cervical cancer among people with HIV. But that if we wait until people are already diagnosed with HIV, we have challenges in both the vaccine efficacy, but also just the fact that HPV is generally already acquired. So going to the next slide, what about once someone's already acquired HPV, can we prevent them from developing cervical cancer by screening them for cervical dysplasia? And what we know is that in resource-rich settings, the widespread use of the pap smear, or papanicular testing, has dramatically reduced the incidence of cervical cancer, again, by more than 90%. And what we know is that pap smears perform similarly in their test characteristics between HIV positive and HIV negative women. But when I often talk about pap smears, I'm often kind of forced to say that this is a system that is, that took 40 to 50 years to really perfect in the United States, and is one that is expensive and quite technically challenging to do well. So if we were to sort of reinvent a cervical cancer screening program in the United States now, I'm not so sure that we would again reach for the pap smear as our go-to vehicle. Much like in many sub-Saharan African countries, rather than trying to build a landline system for telephones, there's a jump to mobile phone testing as mobile phones as a better technology. So in low resource settings, alternatives to pap smears are being used, and there are many reasons for this. So one very attractive way to screen for cervical dysplasia is the use of visual inspection with acetic acid, or VIA. This is a method by which simple table vinegar can be smeared on the cervix and can be manually visualized to see changes where there is cervical dysplasia. It's an attractive option for screening because it is so cheap, but it's important to realize its limitations, and I'll talk about those in a moment. At the same time, now we have the ability to do molecular testing for HPV DNA, and much like you can get an HIV viral load across most parts of even very resource-poor settings, now there would be no reason that we couldn't get HPV DNA testing in these regions as well at low cost and high accuracy. So what we know is that VIA itself, unfortunately, has a low sensitivity. So 50 to 70% of women who have cervical dysplasia will actually be detected using VIA. And it also has a low specificity. So between a half and a third of women who have an abnormal lesion detected by VIA won't actually have cervical dysplasia if you use a different test. So unfortunately, there are significant limitations to this test. And what we know is that the test performs poorly in several high-risk groups. And that includes women who have only recently been initiated on antiretroviral therapy and women who are over 40 years old. So I think that the VIA test is certainly an important tool in our armamentarium against cervical cancer by detecting dysplasia, but I would argue that it needs to be augmented by additional strategies to improve its accuracy. So let's go to the next slide. So here in the United States, our National Institutes of Health often has a mechanism for encouraging research questions, and these are called the provocative questions mechanism. We have one to study cervical cancer in Uganda, but I would like to talk about provocative problems. So I don't want to be a downer, and I hope that I've offered lots of opportunities for hope for dealing with cancer in the setting of HIV, but I want to be a realist and point out that to this audience especially, who are on the front lines of dealing with HIV and cancer, that there are a number of problems that we as a community need to deal with and need to address, and I'll point those out here. So for primary prevention, I've mentioned some of these. So the vaccine against HPV is simply not widely available enough, and we need to think about how to get this vaccine widely available before people acquire HIV infection to be maximally effective. We need to understand more the limitations to the efficacy of the vaccine in HIV-positive persons. And especially, I want to call up this next bullet point. So the initial studies of the HPV vaccine were done with a 3-dose immunization series. And there are very good data to suggest that in select women, the two vaccinations are more than enough to generate robust antibody titers to the virus and offer protection. But what we don't know is limitations to that in the setting of HIV, and we also don't know about the durability of the protection with only 2 doses of the vaccine administered. So as a community, we need to be keeping our eye on how to vaccinate against HPV, when to vaccinate against HPV, what vaccine to use, and whether to use 2 or 3 doses. And to that end, I also want to mention that there are many different formulations of the vaccine. The most recent version is a monovalent version. This covers 9 different HPV types, whereas the quadrivalent or bivalent covers 4 or 2 types. The monovalent is not widely available and is clearly more expensive, but we need to clearly, over time, watch the different HPV types where in sub-Saharan Africa and other places where cervical cancer incidence is high to understand if these vaccines will be protective. Moving to secondary prevention, I want to just say that I think we have to be careful about having unrealistic expectations for using visual inspection with acetic acid. It's a good test. It's one that has availed many women to screening. But I think using it as our sole tool in our arsenal will ultimately be unsatisfactory and will flood the healthcare system with inaccurate pre-diagnoses. So we really need to be careful about VIA. To that end, for every woman that is screened with VIA, there's a limitation in being able to work them up. So these women should have colposcopy and pathologic examination through cervical biopsy, but that often isn't possible. And in an ideal situation, when you identify a dysplastic lesion, you would be able to biopsy it or remove it, and that would require either cryotherapy or excisional therapies. And as Selena mentioned, these are increasingly available, but still limited. Finally, I just want to point out that it's been my sort of mission in Uganda to try and increase access for cancer care. I would say that across resource-limited settings, there is a dearth of the care that is needed to treat cervical cancer, and that's one of the reasons why survival is so poor. The mainstay of treating cervical cancer is radiotherapy, and many countries in sub-Saharan Africa lack access to even a single radiotherapy machine, or like in Uganda, where there is a machine, it often is out of service or incapable of treating high numbers of women. There is a lack of gynecologic oncologists in most countries in sub-Saharan Africa to address the surgical manifestations of this disease. There's a lack of chemotherapy, which is a mainstay of treating the cancer as an adjuvant for late stages. We don't have great treatment guidelines that tell us how to treat this cancer in low-resource settings. And of course, access to surgery for both diagnosis and care is limited. So on the next slide, I'll just conclude by summarizing. I would just like to say that, again, I hope I've impressed on you that cervical cancer is among the most common cancers found in women worldwide, but the burden is really greatest in areas where HPV and HIV are highly prevalent, that HIV increases the risk of cervical cancer dramatically and also complicates screening and prevention strategies, that survival once you develop cervical cancer is poor, so these prevention strategies are key, and that while HPV vaccination may eventually protect women from cervical cancer, we need additional research to understand how to administer the vaccine and how to administer it with the greatest efficacy. So I thank you for that, and I look forward to your questions.
Well, thank you so much, Corey. In the final section of this webinar, I'm pleased to introduce Dr. Sharon Kampambwe. Sharon is the director of the Women's Cancer Control and Prevention Program at CIDRS and has been seconded to the Ministry of Health as the National Coordinator for Cancer Prevention, and she's an integral partner to Pink Ribbon, Red Ribbon. Zambia has had a successful cervical cancer screening program since 2006, and Dr. Sharon will be talking about the implementation of integrated HIV and cervical cancer programs.
A very good afternoon to you all. Thank you so much, Selena, for that wonderful introduction. My name is Dr. Sharon Kampambwe, has been introduced. I've been working in the cervical cancer prevention program for the last almost 10 years. Zambia is found in South Central Africa with a population of about 15 million people. The incidence of cervical cancer, that is the age standardized rate, is at 58.0 per 100,000 women, and we have a mortality rate of 36.2. And women who present below the age of 35 with advanced invasive cancer of the cervix are about 40%, which is very high. And the latest statistics of the prevalence of HIV in women 15 to 49 is about 49.9%. Over 500,000, close to 500,000 of the women in Zambia are living with HIV and AIDS, and we have a population of women from 15 to 49 of slightly over 1 million. Next slide, please. Next slide. So when we talk about the cervical cancer prevention program in Zambia, we begin with talking. We started in the year 2006, the program, and that started with the training of nurses. Nurses are the backbone of the program, the cervical cancer prevention program in Zambia. So you find that the nurses are in the public sector working in the cervical cancer prevention program, and of the nurses, they're using visual inspection with acetic acid and thermocoagulation of cryotherapy, and I'll talk about the advantages and disadvantages of cryotherapy in my later slides. One of the things that you'll find is that most of these nurses are working in far-fetched areas that could be as far as 10 hours drive from the capital city where you find most of the expats. So there was a need to have quality control in most of these countries. You know, in most of these areas, as you know, VIA is a very subjective test. So what we added to our screening program is having a household camera, a digital camera, where the nurses can be able to take a picture, and they can be able to load it on our website consultation page, and the experts can be able to help and also keep that cervicogram as part of the file for the patient. The program has screened over 250,000 women, and we've been able to treat over 50,000 women for precancerous lesions. Next slide. When we look at the graphs that have been presented before us, looking at the graph that is on the left to begin with, we are looking at the women, looking at the way we have been screening women. So the women who come into the program, we have women who are coming in with HIV, we have women who are HIV negative, and we have women who do not know their status. So about a quarter, 25% of the women that we have seen from 2006 to 2011, you see that with these women coming in as HIV infected women. And then we've seen that when we did the analysis at 2013, we saw that the women were going to about 20%. And again, now the latest data that we're having from most of the sites with Pink Ribbon, Red Ribbon, we've seen that 23% of the women who come in for screening are HIV infected. Then when we look at the other slide on our right, we'll see that apart from the women coming in with HIV, we find that 38% of these women will also come in with lesions. And these are the ones who are HIV positive, and they also have lesions, VIA positive. And most of the women also need to be treated with cryotherapy, or indeed we treat them with thermocoagulation that can be made available. Next slide. I think what is very cardinal in this discussion that we are having today is that how do we link the HIV program with the cervical cancer program? This is a very great opportunity that we have. In the program, there are three key areas that we have: the women who are living with HIV, or the women who are coming in and don't know their HIV status. To begin with, first, all the screening programs that we have in Zambia, majority of them, unless they have an HIV counseling and testing clinic, then they do not really have to do, they can just send the women down the corridor. But all the nurses who are providing screening are also trained in psychosocial counseling for HIV. So they also provide HIV counseling and testing to the women who are coming in. And apart from that, so that in the program, should they find a woman who comes in and we test for HIV and they are HIV positive, there is a referral system to get them enrolled into the ART care. In the same vein, women who are enrolled in the HIV clinic, whether they're not yet on treatment or they are already on treatment, they are also referred to come for screening once the doctors or the nurses or the health person who's seen them realizes that they are not yet, they haven't been screened for HIV. So in the enrollment form for the HIV program, there is a part where there's a question that is asked: have you been screened for cervical cancer? And if they are not, they use a referral form to refer them to the cervical cancer screening. And you find that the screening clinic and the HIV clinic are very linked. One of the innovative ways that the nurses also work between the nurses in the screening program and the nurses in the HIV program is that women come sometimes and stay for a long time waiting to get treatment, to get their drugs. And we find that what the nurses would do is that while the women are waiting to get their drugs or to find out their results or to get their blood drawn when they come for the various tests for HIV, they can be gotten to get screened. And in this way, we have a constant number of women who are coming in for screening. We also have mobile units working with the Zambia Defense Forces where they are providing HIV counseling and testing, and they're equally adding cervical cancer screening to this. And in our data forms now, we have also upgraded, working with Pink Ribbon, Red Ribbon, where we are also disaggregating information by HIV status. And the Ministry of Health in the DHIS tool that we have now, we've added a component of HIV. So we want an indicator how many women who have HIV that were screened for cervical cancer and how many were referred into treatment for ART if they were found cervical to have HIV while coming for screening. Next slide. What are some of the opportunities and challenges that we see as we deal with cervical cancer and HIV when it comes to implementation? One of the key things that we see is that the opportunity is that we could be able from that side, and I emphasize that it has to be from both the HIV side and the cervical cancer side, that we put in indicators for HIV and for cervical cancer. And this shouldn't be an ad hoc thing, but it must be there in the way that we are seeing the HIV patient. It must be embedded in the work that is being done in the country, and not just the initiative of few clinics, but as a national policy that women who are coming in for HIV treatment must be offered cervical cancer screening. So this is an opportunity. And the women who are coming in for screening have an opportunity to get tested for HIV. The other thing is that the screening program itself also provides an opportunity for HPV vaccination. The screening program in Zambia has led to the piloting of the HPV vaccination for the young girls, for the adolescents, and also putting up HIV prevention programs, because we're looking at young girls who are most likely, if they are not sexually exposed, most of them are also not HIV infected. And we also have to look at new technologies that we can be able to screen. Most importantly, how do we support that nurse who's making, because the nurses in our screening program are the backbone of the program. So how do we support them wherever they are with information, with being able to consult, with being able to give them answers. And the stigma of HIV and cervical cancer, one of the greatest stigma about cancer in our country, like many of the other low resource setting or other countries, is a fear of death. And then if you add HIV, most of the women said, well, I already have HIV, now you're telling me that I also have cervical cancer. That itself presents a great challenge. And also being pointed out that every woman who has cancer of the cervix is also HIV positive, or if you're HIV positive, then also have cervical cancer. But with these very challenges, with these very opportunities that present, we should use these opportunities of this stigma for how we have solved the stigma of HIV. We can also apply some of those to cervical cancer. In terms of challenges, you find that most of our countries are really rooted towards treatment. And even when you look at the massive burden that they have of malaria, the massive burden that they have of HIV itself, the massive burden of tuberculosis, but we have to look at NCDs because NCDs take time. So people sometimes, because a woman can be walking around with cervical cancer and looking healthy, but once she gets sick, it's a cost to the government. So even in our computing priorities, prevention must become cardinal in whatever we're doing. And we should avoid having silos in that we should make sure that these programs that we're having, if we're promoting HPV vaccination, we have DREAMS that has come up, we have HPV vaccination that has come up, school health programs, all these have to be married together. Challenges of cryotherapy. Cryotherapy in our setting, we have to import from South Africa. There's issues of time, the logistic nightmare that it is. There's also the issue of cost. So new ways of dealing with such challenges must come up. When we look at thermocoagulation, yes, it does not need gas, but there's issue of what we call load shedding in Zambia, and that we're not having electricity all the time. So you still have to reschedule. And the more visits you make for that woman, the more difficult it is for her to come back. Next slide. So thank you so much for having me on this webinar, and I hope that we'll leave time for questions where we can be able to discuss the various questions that people have come up as far as implementation of the HIV program and cervical cancer programs are concerned. Thank you.
Thank you very much, Sharon, and of course, thank you, Corey and Selena. That brings us to the end of the presentation portion of this webinar, the double burden, HIV and cervical cancer. And thanks, of course, to our presenters, all of you who joined us. But those of you who are staying for questions, please don't go away because we are now, we have about 8 minutes, according to my Apple Watch here, and I have a lovely range of questions for each of our panelists. Please continue to write them per chat box, and I'm going to direct a number of questions to each of the panelists and ask them to respond in a succinct way. So Selena, first of all to you, there actually have been a number of questions from Pakistan, India, other places asking, what about capacity building, as well as capacity building here on this continent in Africa, and what are the opportunities to collaborate with Pink Ribbon, Red Ribbon? So I wonder if you could speak to some of those capacity building opportunities, but also more kind of structural collaborative opportunities with your organization.
Great. Well, thank you so much for the question. We are a very small and young program, and we're looking to expand. So we would be happy to speak with other countries that are interested in working with us. And you can just send us an email, find us on our website, pinkribbonredribbon.org. One of our main focuses this year is going to be publishing more case studies and lessons learned, because we think that from the experiences from Zambia, for example, and from the other countries where we work, there are many lessons that the countries can share with other countries in order to scale up work. So we are talking with organizations such as UNAIDS, with PEPFAR, with the Global Fund, with many others about ways that we can share messages and lessons learned from cervical cancer screening so that we can increase access to screening. And we'd love to talk to more countries about how to do this work. Thank you.
Great, thanks, Selena. And this question coming to you, Corey. What about non-sexual transmission of human papillomavirus? So the questioner was asking prior to sexual debut, do we have any epi on that?
A great question. Thank you for that. We do think that the primary mode of HPV transmission is through sexual contact, but I would say that there's preciously little research on other modes of HPV acquisition. I think it is probably the minority of cases which are acquired outside of sexual contact, and therefore, from a global scale, prevention efforts would be best aimed at looking at that. But I think clearly this is an emerging field, and I think as a virus that's transmitted through mucosal surfaces, there certainly could be other modes, but I don't think they would be predominant.
So staying with you for a moment, Corey, the VIA screening, you mentioned some of its limitations. Are there anything immediately that we could do to actually sort of tweak it in order to improve or curb some of those limitations?
Yeah, thanks for that question. So I think that there are two things that would come to mind quickly. First is that we want to be careful to apply the VIA in appropriate populations. So understanding its limitations in women who are older than 40 and those who recently started antiretroviral therapy. In addition to that, our data that I didn't show today shows that the majority of women who are being screened with VIA in HIV clinics are those who are in routine care and on antiretroviral therapy. But we have found that the median CD4 count of a woman presenting with cervical cancer in Uganda is close to 400. So this means that when we roll out VIA screening to HIV clinics, we have to be very careful that we're screening all women, not only those that are there with low T cell counts on antiretroviral therapy. So one, make sure the population that we have for screening for VIA is a good population and a broad one. But then I think we need to bring on adjuvant tests and point of care tests for the VIA that can be used in conjunction. Probably the most promising at this point is point of care HPV DNA testing. It's now been shown to be accurate, affordable, and can be self-administered by a woman who actually can swab herself to test for HPV and high-risk types. But in addition to that, there are a number of biomarkers that are being developed as point of care diagnostics, things like looking for antigens that are suggestive of cervical dysplasia like P16 or E6 and E7. And together, that plus the VIA, I think a point of care diagnostic plus the VIA will be the future, I think, of low-cost, wide-scale screening.
Great, thanks. Sharon, how you spoke about mobile services as well as fixed clinic services. If you had to put those, where would you put more of your dollars, in mobile services or fixed clinics? And I know the person who asked this runs a mobile service, so I think, wanting to know, is this a working opportunity?
I think what we have to know is both the mobile and the fixed clinic offer a certain advantage. What you have to look at in terms of reaching more women quickly and them having access to screening, mobile services are going to do that. In that you're going to be able to mop up. I can give you an example of where we go into villages in Zambia and we do what is known as a village-based screening. So we can go in a village in a week and screen over 1,000 women, 2,000 women. The fixed clinic will serve as your continuity of care when you are referring those women for further treatment. When we want to know if they have gone for their tests, you need the fixed clinic that is able to pick up the women who need extra services or who need further evaluation. So for a country, once you've reached a certain proportion of fixed clinic, it's very important to combine both, because if you're only using the fixed clinic, reaching a large number of women in a short time is going to take a long time. For you to be able to cover or to have effective coverage of screening, it will take you a long time. So mobile services come in handy in trying to reach effective coverage in screening.
Great, thanks very much to that, Sharon. Maybe a quickie that you could answer very quickly. The screening frequency, and Sharon, I'm going to pose it to you, but also Corey, if you want to come in, screening frequency in HIV positive women, what is the recommendation in Zambia at the moment?
So the recommendation in Zambia, we've actually followed more the WHO guidelines, where now the screening frequency is at 3 years. regardless of HIV status. Initially, we used to say for the HIV positive women, we used to screen them every year. But after analysis of our data, we've seen that screening them every year does not really have that added advantage. And now, like WHO has put in their guidelines for high HIV prevalence areas, 3 years is good enough. So we use 3 years for both the HIV infected women and the women who are HIV negative as the screening age, the screening interval for the women.
Thank you. And then back to you. And in fact, we've got a sudden tsunami of questions here, which is wonderful. I'm going to ask people if they can to just stay another 4 minutes. We'll try and get on as many questions as we can, and then we'll wrap up. But to you again, Corey, I love this one. Is there evidence that digital screening with VIA is better than flashlights with eyeballs? And Sharon, maybe you could also comment. So your comments on that one.
You know, I think we've yet to determine that a computer is better than a human for identification of lesions with VIA. But what I will say is that much like anything else from car repair to heart surgery, the more you do, the more skilled you are at doing this work, and it can be very challenging. You know, cervix looks a little bit different. So I think that what digital technology allows is that oftentimes the people doing the screening, especially in more rural areas, feel very isolated, and there's no one with whom they can check as to whether or not, when they see a questionable lesion, whether it's worth biopsying or ablating. So I think that the digital technology, where it's really been implemented and shown some efficacy, is where you can involve other people in a real-time decision-making process, or even a post hoc quality control analysis. But as of right now, the technology itself doesn't offer more accuracy, but offers the ability to improve accuracy on the spot or with future quality control.
Great, and sort of leading on from that and coming back to you, Selena, there's a question here. Is there an online platform for cervical cancer diagnosis? In other words, an aid where perhaps digital pictures could be submitted for a pathological sort of referral base?
There are a couple of companies that are working on that now and have some evidence that that works. There's at least 3 or 4, and if someone is interested in that, you can write to us at Pink Ribbon, Red Ribbon, and we will link you up to those companies to look at their technologies. It's often called digital cervicography.
Just probably, Linda, a quick comment. I think, like in Zambia, what I mentioned, where we're using a digital camera as an added advantage, like Corey has rightly pointed out, apart from just aiding in making a decision in that the nurses can be able to load. We have a platform where the nurses can load the picture, which we call in our eHub, which we call website consultation, and the doctors can get an SMS, an alert, or even on their smartphone and be able to answer. We have seen in one of our papers that we've written by Betman is that we did see a change. There was an increase in the sensitivity when they were using the digital camera. But that has to be seen, because in a way it mirrors the colposcopy, but it's with a lot of arguments as well. But we have seen that the nurses apparently see lesions better, and also their decision making of magnifying. But some other schools of thought will say no, maybe they overtreat because of using the camera. But that is the advantage we saw, is that we did see an increase in the sensitivity to a certain extent.
Great. So maybe I'll ask any one of you to answer this. There have been a couple of questions in various shapes and form around the role of gene expert. As you well know, particularly on this continent, we are seeing some rollout of gene expert. So how does that figure into the whole story? I'll start perhaps with you, Sharon. Are you guys using gene expert at all?
So we did a pilot with different tests, and we did include GeneXpert, using the GeneXpert that they're using the TB program, but using it for cervical cancer, using the reagents for cervical cancer. What we did find is that yes, it had a better improved sensitivity and specificity as expected. The challenge of GeneXpert is right now we have it only in our provincial centers. So that will mean that we'll still need to transfer the various specimens that we're going to test to take them to the provincial centers, which itself gives us time. But if we can find a way of implementation, I think GeneXpert does offer a lot of hope in terms of screening right now, improving screening and maybe moving away from VIA. But it's more of the implementation challenge that it can pose.
Great. I'm going to end on this last, perhaps one of your tough conundrum questions, or maybe not, Corey. Question here, do we know why cervical cancer pathogenesis is not altered by the degree of immune suppression? I think it is a vexing question, and maybe you have some ideas, and then we'll wrap up.
Yeah, thanks. So it is a vexing question, and I would suspect, and I hope to be able to answer this better in a few years with our work, but I guess I would say that I think that there is a lot in the local microenvironment of the cervix. I think we probably see quite a bit of T-cell functional dysregulation, even if it's not a quantitative dysregulation. So even in women who have high T-cell counts, I think their T-cells are not functionally working as well in the local cervical microenvironment. So I think that's one issue. And the second issue, I think, is that there are increasing data that actually HIV itself is a very potent carcinogen, so that there are effects of HIV, and those could be HIV integration into the human genome, into oncogenes, or HIV replication leading to the production of a number of inflammatory and angiogenic cytokines, all that contribute to the pathogenesis of cervical cancer. So although quite technical, I guess I would say that the reduced immunity is only, as measured by your peripheral T-cell count, is only one marker of the broad effects HIV has on your immune system. And then I think we'll find that local immunity, local T-cell immunity, and also how HIV elaborates a number of different inflammatory and precancerous cytokines will help us to understand how this disease is perpetuated.
Well, thank you so much to, first of all, Selena, for bringing the collaboration with Pink Ribbon, Red Ribbon to this webinar, the International AIDS Society, to the team in Geneva helping us do this. Really appreciate all of you for that. And of course, huge thanks to Sharon and to Corey for your time and for these great slides and your expertise this afternoon. Brings us to the end of the question and answer portion. Thanks everyone for your great participation. I think we had upwards of 200 people on this webinar this afternoon. I think shows huge interest in this burgeoning problem, and I look forward to seeing many abstracts and much enthusiasm in France and in Amsterdam to come. So thanks to everyone. A recording of this webinar will be available to all of you who've joined us today, and of course you will also be able to download it from the International AIDS Society website. Hope to see you all soon and have a good day. Cheers.